Hello, HSC 110, Medical Terminology and Body Systems. This is Dr. Teresa, and in this video, we're going to be going over Chapter 8, the sensory system. We're going to start talking about the eye. So some of the language that you're going to hear throughout this chapter will be words like aqueous or aqueous humor, the choroid, ciliary body, ciliary glands, cones, the conjunctiva, the cornea, extrinsic muscles, the fovea centralis, the iris, the lacrimal glands, the lens, the optic chiasma, the optic nerve, optic tracts, pupil, retina rods, sclera, suspensory ligaments, the tarsal glands, and the vitreous humor. So let's walk through some of these structures. The tarsal glands are one of the external structures of the eye, and they are in the eyelids. The tarsal glands are responsible for a more oily secretion by your eye. I'll let that there. We also have ciliary glands, which are modified sweat glands. And these are located between the eyelashes that will produce the fluid or the sweat for lubrication. The conjunctiva, this is the external membrane that will cover the entire portion of the exposed eyeball. Also, it lines the eyelid and secretes mucus. The lacrimal glands, these are the glands that are above the lateral commissure or the outer end of the eye. These glands will have a duct, which means they're going to be an exocrine gland. And they're going to, I think we know this, these glands are responsible for your tears, for the release of your tears. So you have multiple other structures releasing fluids and lubricants within the eye, but your tears, they are specific to the lacrimal glands. Tears will contain antibodies, interestingly, plus enzymes. The enzyme within tears is called lysozyme, and they can kill bacteria. So you can see that a tear is a purifier, isn't it? In more ways than one. The tears will come through structures called lacrimal canaliculi in the medial commissure, or the inside corner of the eye. So they're being produced on the corner of the eye near your nose. The canaliculi will drain into what's called the nasolacrimal duct, and then will empty into the nasal cavity. If your eyes get irritated, you will produce tears. When you have an emotional release, or even like you hit your nose and your eyes water kind of thinking, okay? There are many things that can trigger a response in the release of the lacrimal glands. Here's a good picture on this slide that shows us where everything is located. So let's just walk through that. Okay. So here are our lacrimal glands. They're actually on the outer portion, above your eye, kind of lateral portion. The nasolacrimal duct goes right into your nose. We can see the lacrimal canaliculi coming at that, like the corner of your eye, which will then empty into the nasolacrimal duct. That little piece of pink flesh that we notice at the corner of the eye is called the medial commissure. The lateral commissure is the lateral most, I'm going to call, say, corner of the eye. When we look at the lateral view of the eye, we can see where everything sits a little bit better. So we see bones of the skull. And then we can see the lacrimal gland itself sitting up underneath it and kind of on top of the eyeball. Different representation from that anterior view. I feel pretty big difference. But in this view, the lateral view, we also get to see that tarsal gland. The conjunctiva, again, would be this layer or very thin tissue that will cover the outside of the eye and the inner portions of the eyelid. Okay, now let's go over the muscles of your eye. You have what are called extrinsic muscles, and you have 6 of them. You have a superior and inferior oblique muscle. Superior oblique sits on the top, inferior oblique sits on the bottom. We'll go over their function here in a second. As far as what motions they control, I do want to say on the quiz, you're going to have to know which direction these muscles move your eye. Superior rectus is on the top of the eye. Inferior rectus is on the bottom. Then you have a medial and a lateral rectus. So the let's go over some of their functions. You have a table in your book, page 246. That's really nice and easy. So the superior rectus muscle, let's start there. We'll kind of go through the chart. Okay. The one that's on the top of your eyeball will deliver you the ability to look up. Your inferior rectus will pull your eyeball down. And if you look at how they're connected, I think it makes sense. So if we look at the superior rectus muscle, superior tells us it's on the superior aspect of the eye. If it contracts, it's going to pull the eyeball to have it look up, and same, just the reverse will be true with the inferior rectus muscle. Now, the lateral rectus muscle will deliver lateral motion so that you can look to the side, and then the medial rectus muscle will deliver the ability for you to look towards your nose. Okay, now the oblique muscles, they work a little bit differently. The superior oblique, it is on the top of the eye. That's telling us its location, but it will move the eyeball obliquely. So it will move it downward and lateral. Okay, just by the way it connects. Now, I don't think to have the best picture in your book or in our PowerPoints to represent how this guy attaches, but the inferior oblique muscle, you can kind of get a better idea of how it wraps both of these muscles, whether they're superior or inferior oblique. It kind of wraps the width of the eyeball. So it's yanking it to one side to its origin. So the superior oblique muscle, again, moves the eyeball down and laterally, whereas the inferior oblique will move the eyeball upward and laterally. So movement as far as extrinsic eye muscles of the eyeball, the 2 exceptions here in naming and motion categories would be inferior and superior obliques. Okay, now let's go through some of the internal structures of the eye. Inside of our eyeball, okay, we have fluid. You likely know that. If you've been through an A&P course, or maybe even biology course, you may have done a dissection where you got to see the inside structures as well as fluids of the eyeball. So we have 2 types of fluid in the eyeball, or I should say 2 chambers. And then we name the fluids differently. So in the posterior chamber of the eyeball, the fluid within there, it is gelatinous. It is called the vitreous humor. And then in the anterior compartment of the eye, that is going to be filled with what we call aqueous humor. So the posterior compartment of the eye will go from the lens all the way back to the retina. The anterior compartment is going to be from the lens to the cornea. Now let's walk through some of the parts here. Okay, so we can see the conjunctiva. We already mentioned that was a thin epithelial lining that will cover the anterior portion of the eyeball. By the way, if you get like pink eye or conjunctivitis and inflammation in the conjunctiva, that's something that's irritating that type of tissue and or lining. And you can become very light sensitive in those instances, and the eye gets really irritated by whatever's in there. And it can be created from different origins. Okay, so then we have this very front portion of the eyeball that's called your cornea. The cornea, if you close your eye and you put your finger over your eyelid and you kind of roll your eye around and you feel like the bump on the front part, that's, you're feeling your cornea. Now there's, it's hard to repair a cornea. So if you scratch it, it will hurt, but it doesn't heal super quickly. So corneal abrasion would be what we would be dealing with in that case. Then you have your pupil. I think we know what our pupil is. That's the black dot within the center of your eyeball that allows the light through. The iris, that's the colored part of your eye. Behind the pupil and the iris, that's where your lens sits. On either side of your lens, you have structures that will anchor it to the sides of the eyeball, and one muscle that's going to be in charge of assisting in the movement of your eye, or adjusting to light, or moving the lens if necessary, sort of, would be the ciliary body. Okay, we'll go through this a little bit better in a minute. The suspensory ligaments anchor that lens down to the ciliary body. The very back portion of your eyeball, that is your retina. I think we know that. And coming out of the back side is the optic nerve. On the outermost portion of the retina, okay, so the retina is that innermost lining, you have a layer then of tissue called the choroid layer. And then the whole white part of your eye is called the sclera. So let's get a little bit more specific in some of these structures and what they do or what they help with. So the sclera is that outermost layer of the eyeball. We mentioned the cornea. The cornea is like the very front part of that eyeball. Interestingly, you can get a cornea replacement or transplant from somebody else, and your body won't reject it so far that we know. The middle layer around the eyeball, that's that choroid layer that we mentioned. And this is really the layer that will contain a lot of vascularity so that there's nourishment to the eyeball. The iris of our eye, the colored part, this delivers the pupil okay, its ability to open and close or get narrow, constrict or dilate. We have some muscles within the iris. There's the sphincter pupillae, which will contract in the presence of bright light. And we see this, one reason that when you go to a practitioner and they shine a light in your eyes, they're looking for a lot of reflexes regarding your eye to take place. And one thing is the constriction of your pupil when they shine a light in it. When we focus on something that's far away, okay, we want to bring more light into the eye, therefore the pupil will dilate. We know that and I mentioned this, that the retina is the innermost layer and at the very back portion of the eye. Within the retina, we have 2 layers. We have an outer layer that absorbs light and stores vitamin A. And then we have an inner layer. And this is where we do a lot of our sensory detection. The nerve endings in that inner layer, this is where we have rods and cones. So the rods, okay, pick up things when lighting is not great. And then the cones see for color. They are what delivers us the capacity to see in color. The fovea centralis, this is a spot near the center that will only have cones in it. If we only have cones in this spot, again, this is what delivers us the ability to see color. So if we have damage here, we would have an inability to distinguish between colors. And this is part of the problem when someone's colorblind. Sometimes we have what we call a blind spot. And that's because we have what's called an optic disc. The optic disc is the area that's going to surround the optic nerve, the very back part of the retina. Now the lens, again, behind the iris, it is transparent, or supposed to be. It's flexible and it has a crystal-like structure, which is interesting if you think of how a crystal handles light. Held up by those suspensory ligaments that I mentioned, which are then attached to the ciliary body. The ciliary body will merge with that choroid layer of the eye. Remember, from the outermost layer to the innermost, it goes sclera, choroid, retina. I mentioned that the lens, indirectly mentioned that the lens was the separator of the anterior compartment, in contrast to the posterior compartment of the eye, the difference being what we call the fluid within each compartment. Aqueous humor being in the anterior compartment, A for aqueous, A for anterior, and then vitreous humor being within the posterior compartment of the eye. The ciliary body delivers us the ability to accommodate or make the lens thicker, change the way the lens is able to refract light that comes through it, which is pretty cool if you think about it. So yes, it's crystalline, but it also is kind of flexible, right? A little bit of sponginess to it. So the way that vision works is kind of cool. The eye will perceive an object when the light is reflected from that object. Okay, so it's something outside of us, reflects light back to us. It will pass through the cornea, will have to pass through the pupil and then the lens and then to the retina. The rods and cones in the retina are stimulated and send impulses to the optic nerve, which will transmit a signal to the brain. You have two optic nerves, one from each eye, that will cross at a place called the optic chiasm. And we mentioned that within our neurology section. When the nerve fibers come out of that crossing point, we call them tracks then. So then the tracks take the information back to the occipital lobe of the brain where it's interpreted. And actually, everything's upside down and your brain flips it, or the way that we see it. Now, the injuries to the eye, I honestly am surprised we don't have more eye injuries. It's fascinating to me. They do have protection, but for what we do to ourselves, it just baffles me that there aren't more eye injuries. But because of the way they're set within the skull, within the socket, the eyelids and eyebrows, and well, a little bit with the eyebrows and the eyelashes doing the primary bulk of the protection, that is helping. Now, if you get something in your eye, you have your oils and your tears. Remember, those tears can help purify. The cornea does have self-repairing ability. I mentioned that it hurts when you scratch it, but it takes a minute to heal. Most injuries do heal within 24 hours, and we say that because it happens more frequently than we are aware. If you go through a trauma, you can have a detached retina result in that. And we've come up with some amazing treatments for eyes, even LASIK eye surgery, phenomenal, where we can change the shape of the lens long term, right? So that other things aren't required. Now, there's risk with that too, as with anything. Anytime you have a risk of injury, you need to have an informed consent. Okay, so when we're talking vision disorders, there's a nice chart on page 249 in your book. We'll go through some of this. Now, myopia is the medical term for nearsightedness, and it tells us that there's an elongated eyeball. This is when we can have laser surgery, LASIK. If we have hyperopia, this is farsightedness, and the eyeball is more flattened and will require a corrective lens. And if you look at these pictures, it kind of shows you how the light has to travel and what it's hitting and what needs to be done in order to correct the vision. It has to hit like right in the backside, and if that lens and eyeball aren't shaped appropriately, that's going to contort the way the light is refracted. So presbyopia, this is an age-related farsightedness. It's when the lens doesn't move quite as flexibly anymore. An astigmatism will create blurred vision, and this has to do with an odd shape of cornea or lens. Amblyopia is what we call lazy eye. It's an abnormal dominance of one eye, being a lot stronger in vision as well as mobility. Okay, this has a lot to do with those eye muscles. Okay, if your eyeball is not looking forward, okay, that is going to change the way that light is able to come into the eye in many situations. So its ability to focus will become less. Diplopia is double vision or misalignment of the eye. When we have this diplopia and misaligned eyes, we wear a patch, corrective lenses, or deliver surgery. A strabismus, that's cross eyes. Okay, so eye exercises to help with the muscles, corrective lenses, and or surgeries will help. Color blindness. This is, again, disorders of those cones, right? Color blindness has a large genetic predisposition, generally in males. So if we have night blindness, that's going to have to do with a dysfunction in the rods, okay? And it is associated with aging. Now, for your quiz, you're going to have to have an awareness of each of the ones that I just read through. So I would look at that chart as well on page 249. It goes through the descriptions of them as well. Okay, so as far as let's go through some of these other things as well with diseases and disorders. Okay, we mentioned conjunctivitis, which is pink eye. It doesn't have to be called pink eye, though. You can have an inflammation of the conjunctiva caused by chemicals, allergens, viruses, bacteria, fungus, highly contagious if it's pink eye. Just personal story. I did have an aunt who had a chronic conjunctivitis, light intolerant. It wasn't contagious. It's just developed, and then she wasn't able to control it. She just had to turn the lights off a lot. Cataracts. Okay. A cataract, we hear a lot about this. This does happen with aging. We get exposed to bright lights often, like you don't want to stare at the sun. Your lens becomes damaged due to the bright light or specific frequencies of light coming through the lens. And it's generally now it's created or treated, with lasers. Lasers are cool. And glaucoma. Glaucoma is when we have an increased pressure within that eyeball. You have an increased production or blockage of the drainage of the aqueous humor. Remember that aqueous humor is in the anterior compartment. So something is stuck or blocking or enhancing the creation of way too much aqueous humor. You can have a gradual onset that your eyes hurt, your vision gets poor. You might see halos of light, then you'll know you're having glaucoma. This can lead to tunnel vision, meaning periphery isn't able to be sensed or detected, and it can lead to blindness. If you catch it early, these pressures within the eyeballs can be corrected. Glaucoma occurs in about 20% of adults over the age of 40, which actually is not a lot if you think about it. but there could be multiple origins for the creation of a glaucoma. So like I think that we utilize the detection of glaucoma to look for other diseases and disorders. Like, why is it there? Why is it doing that? What would trigger the creation? Now, when we get into macular degeneration, we've probably heard a lot about this, okay? Macular degeneration is the progressive loss of your central vision. And it will occur in about 10% of elderly people. Your peripheral vision, however, in this case, will remain intact. So that's interesting. Now, there are two types of macular degeneration. Again, you have to be aware of these for your quiz. The dry degeneration is a progressive thinning of the retina, which right now we don't have a treatment for. When we get to wet macular degeneration, this involves the leakage of the blood vessels within the eye. And sometimes there can be a medication or laser treatment that will help this. We've likely heard a lot about diabetic retinopathy. What this is when the retina becomes damaged. And through that, I think, as we have demonstrated what the retina is and what it does, it is the leading cause of blindness. It involves the swelling and the leaking of the vessels of the retina, or supply the blood to the retina. So it can cause like a bleeding in the eye. The person may see red spots. Usually laser surgery can correct this. But if an uncontrolled diabetic, doesn't get that under control, that will damage the vessels in that area. A vitreous floater, these are tiny chunks of that gelatinous vitreous humor in the posterior compartment of the eye that will float off and make it to the anterior compartment. So when we have these floaters floating in the fluid, then they will impair our field of view a little bit. If you have a lot of floaters, this can be an indicator that you have a retinal detachment. On your page 253 in your book, there are some neat pictures going through the macular degenerations, both wet and dry, and how that can disrupt everything. So if you want, you can take a look at those pictures just to help anchor your understanding of what they are. Again, I believe there's a question in your quiz about that. Just some of the medical terminology that we're seeing when we were discussing vision disorders, and we used the term presbyopia. Presby is a combining form that means old, and opia is the root word that means visual defect or condition. The root opia is also used in conjunction with other combining forms to describe other various eye disorders that we talked about, like myopia, hyperopia, and amblyopia. Okay, now we want to go into special senses regarding the ear. Okay, when we're talking about the ear, we have to talk about the three parts of the ear. We have the outer, middle, and inner portions. The inner portion of the ear, yes, it deals with hearing, but also highly involved in equilibrium. So let's go from external to internal portions. The outer ear, okay, the thing you can like grab a hold of, that's your auricle or your pinna. The purpose, or so we think, is to kind of funnel sound waves into the inner portion of the ear. Let's get to the picture here. Sorry, again. The auditory canal also is the canal that has the external opening in their skull called the external auditory meatus. So then the canal runs into the middle and inner ears. So the portions that are considered external or outer ear are the auricle, as well as the auditory canal. That will end at the tympanic membrane. The tympanic membranes, that's your eardrum. That's going to be your dividing point then for your middle ear. Within your middle ear, you have your ossicles, or the little bones that help carry the vibration from the sound waves that hit the membrane. Such a neat system if you think of how this works conduction-wise, okay? The vibrations that are transferred through this series of ossicles or bones then will connect to your inner ear. And some parts of your inner ear will include the cochlea, the round window, the oval window. The oval window is what will link onto the ossicles, transferring the vibration of that sound into specialized cells within that inner ear. So again, cochlea, round window, oval window, a part called the vestibule, the semicircular canals. You also have your vestibulocochlear nerve. If you remember, that is the name of one of your cranial nerves. And then your eustachian tube that will drain that middle ear down into your pharynx. Within the auditory canal, okay, you are going to have your ceruminous glands. Your ceruminous glands will produce cerumen. Cerumen is one of the types of secretions that your glands can produce. Cerumen is only produced in the ears. That is your earwax. It helps to lubricate and protect the ear. Also help, trap any foreign particulate that gets in there. So when we talk about the tympanic membrane, that is our eardrum. The medial side of the middle ear is mostly bone. Okay, by the way. It will have a membrane on the most medial portion. I already mentioned it. That's known as the oval window. Beneath the oval window is what we call the round window, which will allow fluid into the inner, or from the inner ear to move. The tympanic cavity, that is another name for the middle ear, by the way, houses the ossicles that I mentioned. The malleus, which is the hammer, the incus or the anvil, and the stapes or the stirrup. And if you look at their shapes, that is why they're named that. Then again, I mentioned the eustachian tube, which will connect this middle ear or tympanic cavity to the pharynx. Yawning widely will help balance the pressure between these areas, okay, the tympanic cavity and the pharynx. That is one reason, like why if you're on a plane, you might need to yawn. You need to be able to balance that inner ear pressure. Okay, so yawning can help change the shape, kind of stretch things out a little bit. Also, when a child specifically gets tubes in their ears, it is to help drain this area. The anatomical positioning of the eustachian tube in a child compared to an adult is different. And that one reason that there's a lot of congestion is just because of, age. Okay, so when we get then to the internal ear, we can look at some structures. Remember, the oval window will connect the tympanic cavity with the inner ear. The inner ear structures reside in a hollow tunnel. And this is known as the bony labyrinth. There are three components. They are the cochlea, the vestibule, and the vestibular canals. I'm sorry, semicircular canals. The cochlear and vestibular nerve will transmit information from these areas. The cochlear nerve will give information about hearing to the brain, whereas the vestibular nerve is the one talking about balance. They will join to form our vestibular cochlear nerve collectively. These structures are going to be filled with a fluid that we call perilymph. The bony labyrinth will contain membrane-covered tubes called the membranous labyrinth, which will follow the track here in here. The membranous labyrinth is filled with a fluid that's thicker called endolymph. So when we're talking about hearing, the ability to hear, this special sense, this is what, even when we're talking about sight, okay, I didn't mention this, but these are fascinating things to be able to be conscious of how they work, okay? So human sight, our eyeballs can only detect and interpret certain wavelengths and frequencies of light within the visible spectrum. And then the inner ear, or our hearing, works on the sound spectrum. Sound waves work a little differently than light waves. So it's cool that we have two different senses that detect two different types of, I guess, information or energy on different spectrums. Super cool to me. Now, here's the thing I want you to know too, just because something is not within visible range does not mean, or even, within your ability to hearing range, right? Doesn't mean that it doesn't exist. It just means that your physiology is not built to detect it. And we can see that even when we talk about like dogs, right? They definitely can hear things that we can't. They can see things that we can't, etc. So just because a human cannot detect it doesn't mean it does not exist. So when we're talking about the hearing, the portion of that membranous labyrinth that's inside the cochlea. There's something called a cochlear duct. The cochlear duct is a spiral-shaped organ of Corti, which will contain hearing receptors called hair cells. Some are short, some are long, some are stiff, some are more flexible. And the construct of the hair will determine what type of pitch it's able to be moved by. We can say it like that. So the sound comes into the auditory canal, hits the tympanic membrane, stimulates the malleus, the incus, and the stapes. These vibrations, again, get transmitted to that oval window. This process of amplification and transmission then will have an impact on fluid in the ear. That fluid is highly relevant. Okay, sound, when it hits anything, okay, it gets amplified. So it's going to require the water actually, or the fluid, or whatever's in the fluid, for part of the amplification process. So the endolymph then that we mentioned, and the membranous labyrinth, will cause something called a tectoral membrane. And if you look at this picture, you can see where that is. Okay, so we have this little membrane here. That's going to get to move. Which in turn will stimulate the cochlear branch of the vestibular cochlear nerve. And then these impulses get sent to one of your auditory centers in your brain. If you remember us going kind of around that map, this is where these signals will go to so that they can get interpreted. Now, when we talk about equilibrium, this has to do with the vestibule of that inner ear and in relationship to the semicircular canals. The hair cells in here will get stimulated by movement, not sound. So it's a little bit different. So it's kind of those hairs being able to detect a shift in posture or arrangement within the environment, if that makes sense. Now, when we're talking deafness, there can be multiple origins for deafness. This is what we say happens when we lose hearing. So this can come from loud noises, okay? If you overstimulate these centers, okay, within that inner ear structure, or anything in this pathway, it can be neurologic. This is when hearing loss occurs. We can either hear things muffled, it won't be clear, okay, because something along this transmission pathway has changed, or maybe it's, not loud. Presbycusis is age-related hearing loss, okay? Those little bones within your inner ear, they can become arthritic, they can become damaged, the fluid can decrease, the nerves can become damaged, all kinds of things. Now, hearing loss doesn't have to be, again, you don't have to lose hearing because of loud noises. This can come from toxins. I think that's actually super common. And then anything within that travel pathway of sound waves that has to get to the auditory cortex, right, for interpretation. Anything that gets damaged by any means, whether it's physical trauma or otherwise, is going to have an impact. Okay, so if you need amplification hearing aids can help with that. Okay, so tinnitus then is ringing in the ear. And this will happen, I'm going to say, for a variety of reasons. We're saying here damaged hair cells in the organ of Cordy, but the deeper root origin can come from many places. Multiple diseases and disorders, again, injury, medications, loud noise, other chemical exposures can create this, or anything that's going to enhance or increase the reception of sound waves really can do this. And again, multiple reasons. So cochlear implants, I think these are super cool. I don't know if anyone knows anyone that has had them. They're very effective. It is a bypass of the damaged structures. And it's kind of magical when the person goes from truly not being able to hear to being able to hear. It's quite a bright light to see. So otitis externa. This is when we get an earache. This could be swimmer's ear. Okay, we get a bacterial or fungal infection within the canal, and it's usually from water. Okay, pain, fever, temporary hair loss or hearing loss, and you have to think about that. If that auditory canal gets infected, it's going to get inflamed, and it's going to create all these other symptoms, and it will create a blockage. So the prevention is a clean and dry ear canal with an alcohol-based solution. And then you avoid going back into the water is what you do. So otitis media then is that infection within the middle ear, also caused by bacteria or potentially a virus. Sometimes this can come from something like an upper respiratory tract infection. It's just all part of it. Real common in infants and toddlers. Again, partially due to the placement of that eustachian tube. You can get swelling, okay? Anytime you have an itis, an inflammation, right, you're going to get swelling of the tissue as the tissue is healing, repairing, taking debris away as you inspire that immune response to happen. And then the production of pus will happen within otitis media. This gets treated with antibiotics, or again, we mentioned tubes in the ear, sometimes surgical procedures. When we get into otitis interna, okay, this is an inner ear infection that we call labyrinthitis. Again, an inflammation in the membranes of the labyrinth. The condition will affect the semicircular canals. This can cause vertigo, severe dizziness, like the room spins, and you're not going to be able to, touch the wall hard enough to be able to stop it. Can cause nausea and vomiting. Meniere's disease, this is when this inflammation just won't go away and can result in progressive hearing loss. This can be treated with antibiotics. Okay, so now next let's go into smell and taste. Some of the words you're going to hear. Antihistamines, gustatory cells, gustatory hairs, histamines, the limbic system, the olfactory bulb, olfactory hairs and nerves, receptor cells, olfactory region, papillae, septum, taste buds, and pores. So the sense of smell can stimulate the mouth to produce saliva. So smell and taste are really closely linked, but we already knew that. We knew that likely because if you've ever had a cold and can't smell, you really can't taste things either. One thing you have to understand with all these special senses, I mean, if we look at it from a primal perspective, they're there to protect us. We need to know if food is bad or rotten or rancid or will kill us, right? So smelling things is really valuable. Okay, maybe we take it for granted a little bit, but and then again, their connection is intertwined. So the sensory receptors for your sense of smell, these are small and located in your olfactory regions on the top of the nasal cavity. So you can look at these pictures as I walk through some of this information here. The sensory cells are called olfactory receptor cells. So when we have a cold, okay, or we've inhaled mold spores or whatever, something has agitated the lining of our nasal cavity, then we have an immune response that activates our mucous membranes to try to take care of any pathogens that are involved. This olfactory region will get blocked. Therefore, that sense of smell can't happen quite right. The receptor cells are neurons that, like we learned about, and they'll have like olfactory hairs. If you look at this picture, you can kind of see how this works. Here we have our the olfactory bulb, okay, cranial nerve. From the bulb, we will have these olfactory filaments, little projections come off. Going to make their way through the lining of the nasal cavity and then have these olfactory hairs within the mucosal layer that lines this passage and cavity. So whenever you inhale an odor, the chemicals will get stuck to the mucus layer. Okay, so I want you to think about this too. You can smell something sometimes. Sometimes you can't actually smell an odor, yet there is a chemical involved in it. We know that for a million reasons. Okay, for example, radon gas, it's odorless. Propane is actually odorless. They add an odor to it so that you can tell when there's a leak. So there are many things that you're picking up. You just can't actually quote unquote smell them, but they're doing something. You're actually inhaling a chemical. So I think this is a fascinating thing to think about too. So when the chemical gets into this mucus layer, it goes through like a digestion. Okay, it gets dissolved or broken apart. And then the receptor cells of the olfactory hairs, they're able to pick up the molecules that have been broken up and then send it up through the nerve to the part of the brain responsible then for being able to interpret what's happening. So the olfactory nerves will send the impulses to the olfactory cortex of the brain. This pathway will flow through, this nerve pathway will flow through our brain and travel through the limbic system. The limbic system is one of the brain centers that are responsible for our emotional processing. So we might have a smell that brings us into nostalgia or into a crisis response, depending on what happened in regards to that smell. So although most animals have a much stronger sense of smell than humans' olfactory receptors are actually highly sensitive. So what that means is this: it only takes a couple molecules to stimulate a receptor or a response. Now, we might be able to detect then by the odor of a person. Again, whether we're able to be conscious of it or not, our nose is picking it up. Okay. We can be able to maybe detect a person's scent that they give off. Okay. And then we can determine if that's something that, as it takes it into our emotional center, if that's going to be something we resonate with, or we don't. Sort of how dogs work, right? Only a little bit differently. So interestingly, scientists have determined that there are only 10 basic odors, and then we have combinations, infinite combinations of those. So they can be sweet or fragrant, woody, fruity, chemical, minty, like popcorn. That's interesting. Lemon, and something that's decaying or pungent. So, depending on who you are and what you've come across, you might be a little sensitive to some of those smells, or they might enhance a mood, right? So which has a lot of indicators of what you can do within a body, because I want you to take this a step further. When we're saying that our smells run through our limbic system, which is responsible for our emotions, can trigger a positive response or a negative response in your body. If it's a negative one, it can throw you into like a stress response. And if we understand what stress does to a cell in your body, something that stresses you out, you have physiological indicators just through senses or through this sense of smell. So to be around scents and smells that deliver you comfort rather than stress will be super helpful, valuable, and relevant. That takes it into like aromatherapy stuff, right? If you can decrease your stress response in your body by enhancing positive emotions, that can have big implications. Okay, so let's talk about rhinitis. Rhinitis, inflammation of the mucous membranes of the nasal passages. Our most common thing would be, or common cause of rhinitis would be a cold or virus, right? Or really anything that gets up there that our body doesn't like or presents us with an immune system response. So an irritation of these membranes will create a histamine release. Histamines are chemicals produced naturally within our body, within some of your white blood cells, and also a cell called a mast cell that release histamines in order to bring blood flow to the area. If we bring blood flow into an area, we vasodilate, it will become inflamed and irritated, but we do that so we can fight any infection that's there and clean up any debris and make sure the tissue's taken care of. So antihistamines might be a treatment for rhinitis or something to bring down the histamine response. You may have heard of deviated septum or perforated septum. Deviated septum generally requires surgical repair. A perforated septum, okay, if you have a hole in the middle, it can be from drug abuse. Toxic fumes, again, inhaling chemicals, doesn't have to actually touch it in liquid form, can be in gas form. You're still getting the molecule up your nose. I think that's really relevant. You can get ulcers up there. You can have problems in there from other injuries as well. Okay, now let's talk about taste. This is gustatory, okay? Our gustatory sense. This has to do with taste buds. These taste buds we're very familiar with. We can actually look at them. Okay, these are receptors for our sense of taste. They're all over the interior of the mouth, including on the lips, sides, top, and back of the mouth. So when we talk taste receptors, it's not all about the taste bud on the tongue. The majority of the taste buds are on our tongue, and they are known as papillae. Within each taste bud, we have gustatory cells that will send tiny gustatory hairs up through small openings in the top of the taste bud known as the pore. So when we eat food, it's mixed in our mouth with saliva. Saliva helps break down our food. It's our step one, kind of, beyond the mechanical part of chewing. Okay, saliva helps break things down. So the compounds that are produced from the breakdown or this step in digestion from with the mix of saliva and food, this is called a tastent. The tastent will stimulate the gustatory hairs to send the nerve impulse to the brain. 3 of the cranial nerves, facial, glossopharyngeal, and vagus, are responsible, all of them, for transmitting taste sensations to the brain. Now, there are only 5 primary taste sensations. So we can taste things that are sweet, salty, sour, bitter, and my favorite one is umami. The word is fun to say, umami. Umami is the taste of beef as well as the taste of MSG. It's like this, it's a richness. Umami is a richness. So you have like this combination of, it's almost like an intuitive thing. Okay. Like, I don't know, like a sensual taste sensation of richness and nourishment all packed into one thing, and you can tell. Some have also said there is a taste for processed fat, which I would agree with this. Oleogustus, okay, 6 taste, okay. So not processed fat, I'm sorry, but just with fats in general, like it's this other level of being able to tell or sense the composition of a food, almost what makes up that response. Individual taste buds contain 50 to 100 gustatory cells, which typically include all 5 or 6 taste sensations. Now, as we talked about, our taste, that ability to taste, is impacted by our sense of smell. So 75% to 90% of people taste comes from how they are smelling at the same time. If a person can't smell, they would be able still to taste sweet or detect sweet, detect salty, detect sour, bitter, and umami. Without smell, a person is able to distinguish approximately 10,000 different flavors. I'm sorry, with smell. So it's like smell delivers us the ability to combine them to get their unique flavor and ingredient application, if that makes any sense. So you're able to interpret vastly differently when you combine 2 senses. I think that's true across the board. Okay, we understand that if we take away a sense, okay, say we weren't able to hear well, our other senses pick up the slack to be able to interpret the reality that we're in. So it's like if you were eating chocolate without the sense of smell, you might be able to tell that it's sweet, but you might not be able to tell that it's chocolate if you didn't know it was chocolate, if that makes any sense. Super fascinating to me. Hold on. Technical difficulties. Stand by. Okay, so when we're talking then, what can go wrong with this, since we have to talk about tongue disorders? What can happen to your tongue to make things go wrong? You can get an infection that's called thrush. That's a fungal infection, okay, that's created by antibiotics. It's a yeast infection. It's just, it may be common for you to think that yeast infections only happen to females. Not so, okay? The tongue is a very common spot for fungal infections. You might get some unnatural growth of gustatory hairs, and this can be reduced by having good oral hygiene. So if you have unnatural gustatory hairs, you might feel like you have a hairy tongue. Medications can create this, but also those of us that drink excessive coffee, tea, or if we use tobacco. Also, radiation treatments might cause us to go a little weird. There's something called burning mouth syndrome, where you may feel that your mouth is on fire. Okay. This can create anxiety or depression disorders. It can arise from a variety of causes, including damage to the taste and pain receptors in the mouth, chronic dry mouth, nutritional deficiencies, hormone changes, acid reflux, and again, infections in the mouth. So the treatment for burning mouth syndrome is going to depend on the underlying cause. You can use supplements. They have hormone therapies that may be helpful, antibiotics. It depends, again, what the origin of the disorder is and what they're able to do with it, which is also, let's put another plug in there for a really complete health history. If you don't deliver a good health history, your treatment may not be right and can cause more problems. So when we go to any practitioner, we've got to make sure we're telling the whole story. Okay, so let's talk a little bit about how this all develops in utero, embryonically, how these senses develop. Some senses, as we know, are not fully functional when we're born. And then we can develop them throughout our lifetime. Sometimes, one will be in disrepair, like I mentioned, the other ones have to bump up their abilities a little bit. The eyes will begin to develop in the embryo during the 17th day after conception, through many different steps and stages. Over the next 2 to 3 weeks after this, the lens in the iris and the cornea will grow. Previous to that, it was like the eyeball and the retina and the lens and stuff. During the 6th week of pregnancy, the lacrimal glands will form. But no tears can be produced until about 3 months after birth, until 3 months of age. The sclera will develop about 7 weeks embryonically. blood vessels, eyelids. And it's not until the 8th month of pregnancy that the pupil will develop and the ability for it to constrict to light stimulation. So during all of this time, the retina will still be forming and evolving. Therefore, the development of the rods and cones will come. The development of the retina will occur between 24 weeks of gestation and 3 to 4 months after birth, when the optic nerve becomes fully myelinated. At birth, the rod cells allow the newborns to see dark, light, and shades of gray. And then the ability to see colors does not occur until the cones mature at approximately 3 months of age. At birth, the infant's eye is about 65% of its full size, and this will continue to grow and change. Eye movements will be uncoordinated. Full color vision will occur between 5 and 7 months old. And visual acuity and what we call stereoscopic vision will continue to improve until they're like a month and a half old. So yes, things are functional, but as we know, we just continue to develop when we get here. As we age, we know that the lens becomes stiffer. We talked about that. Other changes in vision regarding age. As a person ages, their pupils will be less or slower to respond and react. So then when we talk about the development of ears, okay, the ears and hearing before birth and then within infancy. The inner ear in the embryo begins its development in a place of thickening within the head of the embryo at about week 4. This area folds inward, pinches off, and then forms a vesicle called an otocyst. This will begin to form the membranous labyrinth, which then divides further into the cochlea and the semicircular canals. Then we have auricle auditory canal forming during the 4th and 5th weeks of pregnancy. After birth, the ear and the ear canal will continue to grow until about age 9. The ceruminous glands develop about 5 months gestation. And they aren't fully functional until about puberty, which is interesting. They have those ceruminous glands have high function. So to have that put off that far is interesting. Lots changes with hormone shifts. The fetus actually begins to hear at about 4.5 months. So its sensitivity to sound while in utero is known, and we have explored this as well. Young children, and this is evidenced, you can actually go to YouTube and play around with some videos about hearing things within a certain range. Young children can hear a much bigger range of things than a mature ear. So then when we get into the nose, your sense of smell before birth and infancy, we have 4 to 7 weeks of pregnancy, the development of the nose and the nasal cavities By week 10, we have olfactory receptor cells that form, and newborn infants are known to have highly sensitive sense of smell. And think about that. That has to do with like that maternal, probably more of a primal mammalian instinct, I would say, that sense of smell, but very functional, as we just found out. So they can smell their mom and their mom can smell them, which is fascinating too. So the nose and the passageways will grow as the child grows. Changes during life. There will be a diminished sense of smell after about age 60. These receptor cells begin to change. So as in regards to the sense of taste, then, at about 8 weeks of gestation, we have the first taste buds that are formed. In the 12th week, they're stimulated by aroma compounds in the amniotic fluid. Interestingly, newborn babies have about twice as many taste buds as adults. That's interesting. And their preference will be sweet. There was a quiz question on that, okay, in reference to that. So note that. The detection of salty taste will develop at 4 to 5 months. The taste buds then have a lifespan individually of about 2 weeks. I have to make more, right? So the rate of taste bud replenishment, our ability to make more, begins to diminish after 40 or 50 for men and women, depending on their gender.